Healthcare, as well as the rest of the hospitals in the state. And I know you're familiar with these folks, and certainly want to give them an opportunity to speak. But Steve Frame and I and Michelle Sharp from the association asked for this meeting so that we could talk to you about the impact of the state budget on hospitals, and the fact that, as you know, because you've reported on it, and you're opinion leader, so obviously you're well familiar with the budget, but it contains an increase in the hospital tax as well as cuts to hospitals that is beginning to have, and certainly will continue to have, devastating impact throughout the state in terms of the need to reduce or freeze staff, the need to decrease services, and certainly we can talk about both of those, and then really the significant issue that leads to a reduction in access, and also slows down the really important changes in healthcare that hospitals have been leading throughout the state of Connecticut. So Steve and Michelle and I certainly are available and very interested in talking about generally the impact throughout the state, but really thought it was important for the folks from Hartford Healthcare and the Yale New Haven Health System to be here and talk very specifically about the impact to them. So maybe, Martin, I'll turn it over to you.
Sure. Well, thank you, and thank you for having us again today. And you know, I think we talked about this in the context of our last conversation, but as not-for-profit organizations, and Steve can describe the specific terms of the impact, we are paying enormous taxes to the state of Connecticut, and we are being asked to treat a growing number of Medicaid patients, and a combination of reductions in payment and tax are being paid less to do that. I think when we came in and talked before, we had mentioned that the Yale New Haven Health System, and particularly at Yale New Haven Hospital, Medicaid patients represent nearly a quarter of our overall patient population. Yale New Haven is, by a pretty wide margin, the largest provider of care to patients who are insured by the state of Connecticut. And before the recently approved biennial budget, we were being paid about 58 cents on the dollar of cost, as the state defines cost to take care of those patients. With these changes, we will be paid just a hair over 40 cents on the dollar of cost. And you know, given that it's a quarter of our business, you can't shift that. You can't shift that underpayment anymore. Commercial payers are not going to pay it. And we are a mission-driven organization, as the other Connecticut hospitals are. We have a commitment to taking care of all patients and taking care of them the same way. It's one of the great things, you know, about this state. We are the safety net hospital, and we, where a patient is, whatever room they're in, whatever operating room, where they are in the emergency department, has nothing to do with their payer source. It is based on medical need. But when you look at the aggregate impact of the cuts, which start in a week and a half, because the state passes budget, they begin on July 1st. We still have a quarter of our fiscal year to go, so we are making significant cuts just so that we can come in on plan, because as we have talked about in the past, you know, I think the easy thing to do would be to throw up our hands, but you know, we have to run an organization that doesn't get into trouble and that can be healthy and self-sustaining in the long run to be able to meet these services. So when we first saw the governor's proposal and saw subsequent suggested modifications, we had a sense of the impact on our health system, which hits us right off the bat at about $60 million, and the vast majority of that is at Yale New Haven Hospital. And we brought together teams of people and we said, how are we going to deal with this? Because we, you know, have a philosophy that, you know, we respect our employees. We talked in the past about the fact that we did the St. Raphael's acquisition and integration meeting commitments to the state and the federal government to take out a substantial amount of money, and we did that integration and we didn't lay off people. And that's part of a value set that we have, is where possible we do that. That may not always be possible given the significance of the cuts that we were doing, but we started early because we said we got to anticipate that something unanticipated is going to hit us, and it's going to hit us in this fiscal year. And so we are looking at programs and services that may be duplicative. So we have 2 certificates of need that we filed to close urgent care centers in East Haven and in Branford. We're still in the urgent care business, but we're not going to be doing it on as distributed a basis. That's an access question for patients, but on the other hand, the closures allow us to save about $1 million on those 2 initiatives alone. We have about 31 people, I think, affected by that. Through vacancies and through other opportunities, we're going to try and absorb those people elsewhere in the organization. So again, the goal is not to eliminate services that are important. The goal is not to affect people's jobs, but it gets harder and harder because, as Steve can tell you, with the history of the taxes, this has been a progressive reduction in what we get paid, in spite of the fact that originally this was a way to get some money back to the state, but with the understanding that the match money would be returned to the hospitals. So it is going to be impossible to offer services to a quarter of our patients with business as usual and get paid effectively. And Steve has a great expression, but basically we're being asked every other year to provide all of our care to Medicaid patients for free.
That's a big problem. So maybe I could just give you a little background on what's been happening over the last several years, so you could at least put in context this next kind of big hit that everyone is both concerned about and already having to act upon. So I think, as Marna said, several years ago when we started down this road with this new administration, or it was new administration at that point, there was a promise made, and the promise was, look, work with us, allow us to put in this assessment, and if we put in this assessment, while it might impact some institutions individually in different ways, in the aggregate, you'll get all your money back. So it's not really a tax. So we went from a situation where in 2011, the hospitals used to be collectively helped by the state to actually underwrite a portion of the cost for those individuals who didn't have insurance and so forth. And that help was worth about $83 million a year. So once we went from 2011 to start actually paying a tax into the state and then money coming back, that situation began to change in a rather dramatic way. So the first year in 2012, instead of being helped $83 million a year, we actually received a slight reduction in that help, and it became only $50 million a year. The next year, actually, all of the help was eliminated, and we actually started being net taxpayers to the state of Connecticut of about $27 million a year. And the budget at the state level just kept getting worse and worse and worse, so we then found ourselves being net taxpayers of $100 million a year. And then in the year we're in now, we're now net taxpayers to the state of Connecticut of $270 million a year. And in the year we're about to start, which is July 1st, that collectively the hospitals will be net taxpayers to the state of Connecticut of $315 million a year. And we're hoping that's, it's not going to get any worse in the special session that'll be introduced in terms of coming up with the implementers, because I think the administration has suggested perhaps rolling back some taxes for large businesses, but in fact implementing further reductions in other parts of the budget. So in a very short period of time, we've gone from a situation where we used to receive $83 million a year of help to a situation in which we actually have that completely zeroed out, and we actually now pay the state of Connecticut $315 million a year collectively. So another way of putting it, year over year, every year it's been a $100 million reduction, and it's not just give us the same 100 over again. It's 100, then it's 200, then it's 300, then it's 400. So right now, our funding is actually $400 million a year lower, just as a consequence of the hospital tax. So that's kind of piece one. Piece two is, in addition to those changes in the tax, there's actually been substantive decreases in the level of funding for the very services that I think Mario was talking about, which are those Medicaid services. So over the course of the last year, unbeknownst to anybody, because it was not spelled out in any budget document, the administration began to implement a number of reductions in funding for various services. So for example, they decided to reduce all of the funding for laboratory services by 20%. It was nothing we knew about, it wasn't in any budget document, but it was implemented nonetheless. They used to pay for radiology services 100% of what Medicare used to pay, and I think it was 2008 or 2007, which obviously was quite some long period of time ago. And they decided during the course of this past year that that was too much, so we would reduce it to about 57% of what Medicare used to pay in 2007. Again, another substantive reduction. We were expecting rates of increase as it related to inflationary adjustments. Those things have been eliminated every single year. There was a conversion of the payment system. There were certain promises made as to how that conversion would be done. It was promised to be budget neutral. Those promises weren't necessarily kept. We had expectations that if we taught them how to get higher matching rates, the Secretary of OPM promised that those additional funds from those higher match rates would be dedicated to help the hospitals. Those promises were withdrawn and reneged on. So I think when you begin to add up all of these other pieces, what you see is over the course of the last year, there was kind of, when we started the year, we thought our worst situation was losing funding as it relates to this tax. But what we actually found out was we not only lost funding on the tax, but there was another $100 million worth of funding that was withdrawn during the course of the last fiscal year. And now what we see is, with the budget that was just implemented by the legislature, there'll be another $60 million on top of that. So, if you add up all of these pieces, collectively the hospitals are finding themselves in a situation where on a go-forward basis, our funding between taxes and changes to the level of payments, the tax portion is about $400 million less per year, and changes in the levels of payments are about $200 million less a year. So it's a huge change in an extraordinarily short period of time. And this is all occurring at the very time that the enrollment in the Medicaid program is actually increasing. So as part of the Affordable Care Act, more and more people are actually going into the Medicaid program. So we have more people in the program, but the level of funding for those individuals as they flow through the hospitals is declining every single year, year over year.
I just have a question.
Sure.
We went over the tax on the things going forward, I guess, but just so I understand that so in this fiscal year for the state's fiscal year 14-15, this is when all these other things started happening and the lab costs were
Correct.
down 20% reimbursed. Radiology costs, I mean, did that happen over time, or that's down?
It just happened this year.
57 down to 57% as opposed to Medicare.
Yeah, on these kinds of changes, what tends to happen is, and I can get you the exact date so you have the timing, but they began to occur right after the new year, and typically they would publish something in the Connecticut Law Journal saying we're going to be making these changes, and you might get a week or two. Sometimes it's after the fact. It'll say, the notice will go in mid-January. It'll say effective February 1st, we're implementing this change. If you have any comments, you can file the comments. We'll consider them, but the change is going into effect. So there's really...
This is from DSS or OPM?
Yes, from the Department of Social Services, right. So there's really no ability to kind of interact. It's kind of notice, implemented, you can complain, and then at some point in the future, they'll respond to your complaints to say, well, we had to do these things in order to
So those are the two big new pieces, I mean.
Well, and
Well, and
another
then
fairly
the
large
OB
piece was.
the OBGYN rate.
Right.
On April 1st, much to everyone's astonishment, they cut the OBGYN rate to providers by 50%.
Right.
And across the board, in all Connecticut hospitals, the Medicaid births are 50% of all births. And in fact, and actually I have one of my hospitals in Wyndham, I don't mean it quite that way. You know, when the boss is here, you just move right in. In one of our hospitals in Wyndham, it is 70% of all births are to Medicaid moms. And so to have a cut like that, what happens is that providers out in the community aren't going to participate anymore. So in the areas where we have clinics, which is Harvard Hospital and at the Hospital of Central Connecticut, they're really going to become overburdened. So you're going to have less access. And actually, by that sort of, you know, kamikaze move on April 1st, quite frankly, it was helpful to all of us in demonstrating to legislators that this is the kind of thing that has been going on and continues to go on. And, you know, we had obviously the OBGYN providers were up in arms, but it actually, as I said, was very illustrative of what has happened in the last couple of years. And so it was actually helpful, and I think we were, you know, obviously when the governor's proposed budget came out, and I think I had said to one of my CHA colleagues, well, and they said, well, what could happen this year? And I said, he could, you know, cut Medicaid, he could eliminate the low-cost hospital pool, he could increase the tax. And indeed, he did all of those things in that budget. And so we sort of saw the writing on the wall, and all of us worked very hard, particularly with the Appropriations Committee, to see if we could, you know, ameliorate some of those cuts. And to our pleasure, that did happen. I think the Appropriations Committee did hear loud and clear that cutting Medicaid rates would be harmful in terms of, we pride ourselves in Connecticut on access to those of our poorest citizens, and that's what we have in Connecticut. And when you cut rates, you cut that access. And so they understood that. So the appropriations budget, I don't think when we were here last time, the appropriations budget had come out yet.
That's right.
And right, exactly. So we were very pleased with that. They actually sought to restore almost all. I think there's just a couple million to restore the Medicaid dollars. And the Finance Committee actually also, I think, listened very hard to our plea on the tax issue, and was going to redistribute $56 million back to the hospitals. Now, we also realized that, as someone just said to me a few minutes ago, that the governor usually gets what he wants. And by the time the actual budget was voted on, which was the last day of the session, things had changed completely, particularly for the hospital community. We were, you know, there was a much, not as big a Medicaid cut as the governor introduced, but still one that was there. And the hospital tax had been increased from 5.5% to 6%, with none of that additional money coming back to be distributed to the hospitals. So I think the point of us being here this morning is different than it was 6 weeks ago when we were here, is to try to demonstrate that this is really harmful to hospitals across Connecticut, and it's really going to affect access, particularly for those individuals that are Medicaid individuals. They'll have limited access. They'll really be coming to us more and more than they do at this point in time. And I think we've got a special session that's slated for the 29th and 30th. And we've seen the larger corporations who can take their business out of state make their plea. You can't tax us, you can't do these things to us. And we're an industry that is a growth industry in Connecticut. I mean, we represent two of the largest, Yale and Harvard Healthcare we're number 4 with over 18,000 employees. You're just a little bit ahead of us. We're two of the largest employers in Connecticut. We can't go anywhere. We're not moving. You know, our commitment, as Marta said, our mission is to serve our communities. And so to see how the reaction has been for the GEs and the Aetnas, which is positive, but we actually got hit worse, quite frankly, and have been getting hit quite worse.
Let me ask this. I've noted, well, we've all noted, a pretty sharp-edged political reaction to this from some of our legislative leaders. What's your response to that? you know, top legislative leaders from greater New Haven talking, you know, specifically about Yale New Haven health systems, about, well, you read the stories about administrative costs, salaries. They're, you know, they're very sharp in that. What's your reaction to that?
Well, maybe I can comment on just our perspective as the association is, our concern is that's not focusing on the right issue. There is no industry in this state that has done more in terms of contribution to the state's economy. Steve has outlined all of the cuts and the dramatic underfunding. That's done more to transform care, which is an investment in our communities and an investment in moving forward. So this concept of fair share is certainly the hospitals, again, have been a huge contributor. And on the specific issue of executive comp, again, that's not the issue.
Why isn't the issue?
Well,
If you're crying broke, then why isn't compensation an issue?
Well, I think it's fair to ask questions about it. But first of all, executive compensation is very carefully set by community boards. These are very complex organizations that need to be run by very talented individuals. But to your point about the math, it's a tiny, tiny fraction of healthcare costs. And
Well, let me stop you there. We just sat here and heard that East Haven and Bradford clinics are being closed to save $1 million. Some people may be put out of work, and yet your executives make more than that. So, I mean, and then you're asking us to get on your side. That's kind of hard to do. When you're talking about you're broke, you need help, but you pay out millions in salaries.
Let me address that.
And
So Steve walked through the numbers. I mean, over the last few years alone, you're talking about $750 million has been stripped out of this industry. Yale New Haven alone, $117 million coming out of the next 2 years. Yes, we made those efficiencies and those decisions around Branford and East Haven. And we can have the conversation about executive compensation. That conversation actually doesn't happen when other industries talk about the budget as well. The fact of the matter is that we have to make these very difficult decisions, and it's a distraction to the core issues. The core issues are how hospitals are going to move forward in this environment, and that's ultimately what we need to deal with on a regular basis, especially given the changes in the reimbursement mechanism.
And then why haven't you convinced Senator Looney or Senator Fasano?
I think the issue comes down to be fairly straightforward from their perspective, and that is they need money, and they're going to get it. And they know that hospitals are not able to leave the state. So, okay, we look at the situation that we're in right now. We have a number of fairly large corporations that say, and some have said, well, maybe they don't even pay any tax today. So, you know, let's look at the situation for Yale New Haven Hospital. I believe under this budget that would go into effect on July 1st, its tax liability just for Yale New Haven Hospital to the state of Connecticut exceeds $100 million per year. Is there any other corporation in this town that pays that amount of money to the state of Connecticut? I would say there's no company in the whole entire state that pays that amount of tax to the state of Connecticut. Matter of fact, I wouldn't think there's even one company in the entire state that pays that much, even half that much to the state of Connecticut. So I think when you begin to look at this stuff, what we often see happen is the legislature decides and the leadership decides that they're going to effect some cuts and they're going to have to find money someplace. They've decided that for whatever reason, going after hospitals is an appropriate way to get these funds. But you know, this town has to consider what would happen if this institution had available to itself $100 million to spend on health care in this town versus $100 million to hand over to the state of Connecticut to balance the budget. That's the real issue. So if all of the executives at this system or other systems or all of the hospitals all worked for free, I could assure you at the end of the day, these cuts would go into place. It would be irrelevant. So, you know, it's a very easy way to create a distraction to take folks off of the real issue at hand. But the real issue at hand is you have major communities. Hartford healthcare system collectively across their system, is paying into the state of Connecticut well in excess of $50+ million a year. That's money coming out of rather poor communities where these institutions take care of lots of individuals who don't have other means. I mean, don't you think that money is better used to be spent in this community as opposed to building roads or giving car tax credits? So, I think it's a great way to create a diversion, and I think folks can have a very candid conversation about how much is too much in terms of salary. But at the end of the day, even, as I said, even if they all work for free, the dynamics here would not change. They would still be taking out of this community $100 million to balance the state budget. And I think folks in this community should be really angry about that.
And I just, I'll let you go in a second, just have one other question. To my point, I understand that that this all raising the administration stuff is part of it. What I'm really wondering is the two top legislative leaders in the state of Connecticut are from New Haven, basically. And they still are willing to be out there targeting Yale New Haven Hospital. I guess my real question is, if you can't get them on your side, in that sort of, I'm saying that sort of a global sense, why should anybody else? Why should the governor?
I'll take a crack at this and Ben, can weigh in. I cannot tell, I meet with Senator Looney fairly regularly, have for a long time. We have probably had discussions that have demonstrated more commonality than not. I cannot explain to you, what his view is and why his politics go that way, or any other individual. I think that if you look at the record, this budget passed by the slimmest of margins. This was not an overwhelming mandate that the legislature said, we think this is great. This came down to a very, very close vote. And I think that in discussions with a number of legislators individually, they were really troubled by this. Steve has said our effective tax rate is far greater than, Fortune 500 companies that call this state home. I'm not wishing a tax on them, but I think that the issue of fairness is a problem. You remember we talked about it the last time when the first budget came out and Ben Barnes was asked, why are we taxing the hospitals more? And he said, that's where the money is. I think to your point, we're not telling you we're broke. You don't want us to be broke. If the entire hospital, industry in this state goes under, we have a much bigger problem in this state, because the state will spend a lot of time bailing out organizations with money they don't have, and without, I would argue, the perspective and the ability to manage these organizations. I think, part of the question, and, Elliot Joseph, I think, put this, in front of us when we were here the last time, is we have to say, do we think healthcare is just a cost and something that has to be dealt with, or is it an economic engine for this state? This state, arguably, is in trouble. We have, some very critical financial measures that we are not performing well on by any national standard. When the economy went south in 2008, and you look at the modest recovery that has occurred, and I think if you talk to the mayor of New Haven, who used to have a very significant role in the legislature, she would say, as she has said to me, that the medical center in New Haven was the single most significant contributor to the very tentative recovery that New Haven has had. We have been a net investor in the community, hiring people. Alexian didn't leave the state. They came into New Haven because they're looking at robust opportunities, as other pharma is in the Farmington development and others, but they need a successful, robust health system in order, to bring innovation, jobs, and all of, the other things that could be a net positive to this state. So, when we've been, I'll tell you one of the things I say to our management team is each biennial budget, when we get handed what I think is a pretty bad set of cards, the easiest thing to do is to say, we're going to underperform because it wasn't anticipated. But you know what we get paid to do? We get paid to figure it out. We get paid to, make thoughtful, creative decisions with the right set of values. I would argue that we are a very values-driven organization, and the way that we did the St. Raphael's integration, I think, demonstrates that. What we're here to tell you is that it's harder and harder to do, and when you start getting a patient population for whom you are paid less than 50 cents on the dollar of cost, at some point you can't make it work. The historical model in healthcare was that the state government's underpaid, the federal government paid kind of cost, and in order to generate a profit, your cost shifted to the third-party payers. Those who insure New Haven Register employees, Yale New Haven Health System, Hartford Healthcare, United Technologies. We all have done a lot of important work to get our employees to be more responsible for how they live their lives, how they use healthcare services. That's all great, but that takes down our profitability. You want us to be profitable. Across the country, most organizations are saying, given our cost structure and given how capital intensive we are, and given the stress on innovation because healthcare is changing, 4 to 5% margin is a minimum. That doesn't go back to shareholders. That is redistributed. That's how we built the Smile Cancer Hospital. That's how we've put telestroke in place. Those are really important things and important advances. So, I think I agree that we shouldn't get focused on kind of the he said, she said, and throw things out there that become lightning rod issues and not understand the broad contribution that healthcare makes, its importance to the fundamental financial infrastructure as well as the care infrastructure of this country, and try and move towards something that's rationable and sustainable.
I think just listening to dialogue coming out of Hartford, I think there's a complete distrust of the healthcare system, I think, across the country, which kind of goes back to real costs. Maybe it goes back to the charge system, which everyone says really doesn't have a whole lot to do with reality or with the cost of the hospitals. I think it kind of starts there. I mean, if you talk to these two individuals, it starts at that level, and then there seems to be two different directions that legislators are going in, or at least the leadership in the hospitals. I mean, the hospitals are trying to consolidate for efficiencies. I mean, to have smaller numbers, I guess, of hospitals all affiliated together. Whereas all the legislation that's sort of got passed up there goes in the other direction. It looks to keep more diversity, more options. That's how they look at it. So there's fundamental kind of.
Well, I think there's also a fundamental disconnect between. I think as you describe it actually quite well, between the difference between where many of the organizations are trying to move and where at least those in leadership in Connecticut think we should go. And I think the disconnect is between where those in leadership think we should go and where the federal government in leadership thinks we should go. We're responding to what the federal government is asking us to do. And I think if you look at the vision that's been laid out by the federal government in terms of the level of integration they're expecting, how they're expecting organizations to come together to better manage that care, to make the handoffs work from the hospital to the nursing home to the home to the home health agency. Those are the things that all of these organizations are responding to, and appropriately so, because the federal government through the Medicare program dictates probably half on average of all of the levels of revenue that all of the hospitals in Connecticut receive. So when the federal government establishes a vision of what they're looking to accomplish over the next 4 to 5 years, and is going to dictate that through how it funds these organizations, we feel like we have nothing other to do but then to respond and also agree with that direction. So we not only have an issue between how the how those in leadership here perhaps disagree with what the hospitals are doing, they also seem to disagree with where the rest of the country says we should go. So I think that's where the large disconnect is, and if you go to the CMS website and look out at the vision that's been laid out for how the country is supposed to be transforming itself over the next 4 to 5 years, you would basically see, and then compare that to the vision Connecticut is laying out. It's Connecticut saying, no way, we're not doing that. So, we really have a very difficult problem to wrestle with.
Right. I mean, I know they'll argue on the other side, it's not integration, but it's coordination that should be.
You can't coordinate if you don't integrate.
Well, I think that's another disconnect too. I mean,
Right.
talk about that.
So I think that
Different
it's a
approaches.
very practical problem, and I think you kind of hit the nail right on the head in that part of the disconnect is simply because there's not really an appreciation of what the overall expectations are as set as a national agenda about where we are today and where we're supposed to go.
You don't think the disconnect is due to what it costs the average person to make a hospital visit? For example, I had an emergency last year. I was in the hospital all of 3 hours, a little over $1,000. I just can't comprehend for what I got that this would cost me $1,000. So I mean, is that all part of it? Well, the politicians and so forth, their families use the hospitals and so forth, and they just don't understand why it costs so much money. 3 hours. 3 hours in the hospital with just a little thing on my finger,
Yeah.
okay? And then I'm sent home and I get this bill that is just floors me. And then I hear you say, well, we need money, we're broke. So it's.
Well, actually, we didn't say we're broke.
Well, no, I don't hear it that way.
The goal is not to be broke.
The goal is not to be, and I agree with you, and I agree with you on that, but.
You're right, and Mary was right when she said, that there are a lot of disconnect. We didn't get to the way healthcare is paid for right now overnight. It took basically since the passage of Medicare in 1965 to get things as, cattywamped as they are. I mean, nobody who knows healthcare, if you gave us a whiteboard in this room and we sat down and designed the system, would design it and the payment systems the way they are right now. So, there isn't a disagreement there. But I'll come back to the Medicaid discussion that we've been having, and I'll relate it to that $1,000 bill that you got. So, and I know this is true of Hartford Healthcare because, I've had these conversations with Elliot. We do 5-year rolling strategic and business plans. And we look at where we think, healthcare need is going, where technology is going, how it's going to change the delivery of healthcare, how we're going to get paid. And we develop plans that say, we're here right now and we've got to make these changes in delivery, we've got to make these investments because we have a vision of where we need to get to. One of the things that is a cornerstone of the Yale New Haven Health System strategy is that we got to get the value equation right and much better than we do now. And how we define value is the quality and the safety of the care that you're provided over what it costs you to get that care. Because right now, most people would say that's not necessarily clear or in sync. And I wouldn't disagree with that. And so a big part of what we're doing is trying to be more transparent about the quality and safety issues, taking 20,000 employees in our health system through high reliability training, reinforcement. Everybody's 200% accountable for the quality and safety of care. Some amazing, wonderful stories, if we ever want to write positive stories that, about the difference that that's making in not just how care is delivered, but cost savings. But we also created as a health system 4 years ago a plan that said we have to take $500 million out of our expense base at the Yale New Haven Health System. We're about a $3.6 billion organization right now. We got to take that out. And I'm really proud to tell you that we've been moving on that, and we have taken a lot of costs out, and it actually costs less per unit of service. You know, if you take our overall costs and all the inpatients and outpatients that we treated, it costs less in 2014 than it cost in 2013 and then it cost in 2012. Is it where it needs to be? No, but that's where we need to be going. And theoretically, the way that could translate into somebody who has insurance is that we could make the same bottom line, let's say a 4% bottom line, and if we take the dollars out that we are taking out and we had a rational payment system, we could actually go to third-party payers and we could roll back our rates by about 13 or 14%. But as fast as we're taking that money out, the state government is reducing its payments to us. And so what could have allowed us to develop a reasonable healthcare and business model and balance what people who have insurance are paying for healthcare is going into legislatively mandated subsidization of Medicaid. You know, it just doesn't work. You can't take the costs out any faster, because if you take them out faster, then you're going to make mistakes. You're going to end up impacting people's jobs. You're going to do things that you don't want to do.
And it's compounded by the fact that 2/3 of the patients that we see right now are either insured by Medicaid, where we get 58 cents currently, going down potentially to 40 cents on the dollar, or Medicare, where we now get paid 90 cents on the dollar, less than our cost. 2/3 of the patients, or lack insurance completely, because there's still people that lack insurance, regardless of the Affordable Care Act. And our free care and our charity care has not gone down at all. So you take that means 1/3 of the patients that we see bear the burden of the cost of the entire system. And that impacts pricing as well as all the things that Mark was talking about. So as we drive down those costs, the state continues to drive down reimbursements, you lose that momentum.
I have a question about that, and forgive me, I get that, but the question of access, and using your example, OBGYN example, I'm a little unsure of how the access would change under this model.
Because when you lower Medicaid provider rates, not only our rates, but also the independent practitioners, let's say, take for example OBGYNs. One of our hospitals, Wyndham Hospital, and talking about payer mix, it is the only hospital in Connecticut that's a Medicare dependent hospital. It's got an MDH designation, the only one on the 29, because its payer mix is more than 62% Medicare and Medicaid. And no OBGYN that's in the greater Wyndham area, greater Wyndham-Willimantic area, is interested in seeing Medicaid patients. So we have had to bring in from outside and contract with not an OBGYN that's in the community. No, we've had to bring in our OBGYNs to actually serve that community. And as I said, 70% of the births there are to Medicaid patients. So what you see is, so when you go out to, like, as I said, and all our hospitals are in poor communities, New Britain, Hartford, we have 2 clinics there that see low-income and Medicaid individuals. When physicians in the greater Hartford area, OBGYNs in the greater Hartford area and in the greater New Britain area see this reduced rate, they've even said, in fact, you've got a lot of nurse midwives down here in the New Haven area who've said, 30% of my patient base has been on Medicaid. I really enjoy that. That means a great deal to me. However, I can't do that anymore. So you have doctors also saying the same thing. I will not do that. So what they will end up, Medicaid moms who are going to need, I should say pregnancy services. That's not the way it's done. I didn't have children. Can you tell? Are going to rely on hospitals ever more because they're not going to be able to access the community providers.
Okay, so
that's what it is. When you
They
start
go
to knock down
hospital
rates, and
more,
they have been so proud in Connecticut, as we should be. We expanded Medicaid. We have done great things in this state. We had a very low, our uninsured rate in Connecticut was at 8%. For other states, that was amazing. We should be very proud of that. We've done things through several administrations. We've expanded Medicaid. And yet, what we're seeing in the last couple of years is, well, you've got agencies saying, we are ahead of all other states. On the other hand, they are squeezing providers so that isn't necessarily going to be true anymore. I mean, just for example, even taking people we had up to 185% considered Medicaid. Terrific, all kinds of things available to those individuals. The governor's budget called for taking individuals from 133% of the federal poverty level to 185 and putting them in the exchange. Now, some people may say, well, you'll get better rates for that. The point is, that population will be hard. It will be hard for them to come up with the premiums and the co-pays, even with subsidies. So you're not going to see them stay on the exchange. And so that's an issue. And while the budget moved that needle from 150 to 180, that's still putting, these are people who are working, who are struggling, and it's going to be very hard for them. As we've seen in other states, and studies have shown, they don't stay in exchanges. In fact, their children may not even be in the CHIP program anymore. And so that has an effect. So we've made great strides in Connecticut with people who are uninsured and getting people in Medicaid. That's who actually are enrolling now in the exchange. The biggest percentage of the exchange are Medicaid recipients. That's great that they're now getting access to good quality care. You're going to see that all roll back, really, because you're squeezing community providers, and we're being squeezed also. So while the community, I'm not going to take any more Medicaid OBGYN. So you go to our clinics, we're going to have to cut back hours at some point. So it doesn't make, as I said, we have made great strides in Connecticut, particularly ensuring as many people as we can. And I think when you see the kinds of cuts that we have seen for the last 3 years, and we may even see next Monday and Tuesday, I think we really need to re-examine from a policy perspective. Are we going in the right direction? We have been, but we seem to be making a turn and going back the other way.
One thing I don't know how much more time we have, but at least want to get across this point is that there is actually an opportunity to not have to have this conversation. And I think one of the ways to think about how we can avoid having this conversation is, if you look at this budget that the legislature has adopted and presumably the governor is about to sign, it has in it some fairly substantial investments in a whole bunch of things. And I think most folks would agree that investing in things is a good thing. And I even agree that the things that they're planning to invest in are actually good things to invest in. If you look at the level of those investments, in the first year of this biennium budget, it's $1.6 billion increased spending. And in the second year of the biennium budget, it's $2.4 billion. So to avoid this whole conversation that we've been talking about for the last hour and been spending a lot of time trying to get people very exercised about because of how much money is going to be flowing out of their communities to make those investments happen, to avoid the issue as it relates to the hospitals, the only thing that would have to change is instead of it being $1.6 billion, it's $1.5 billion. Instead of being 2.4, it's 2.3. I mean, that's all we're talking about. But it's such a huge difference in terms of what it's going to mean to these organizations and their ability to provide care. So we think there's ample room in this budget to continue to make very large, significant investments, things that I think all of us would think are of value for the future. But there's also an opportunity to basically say, if we just scale back those investments just a very tiny bit, we can actually avoid doing fairly significant damage to something that I think everybody really counts on, which is their ability to receive services in a timely way and to not actually have the cost of those services being increased. So, I think part of the issue is making sure your readers and others understand what the problem is, and then also helping your readers to understand, is there a way to actually avoid the problem occurring? And I think from our perspective, there is a way to do that. It's a fairly straightforward way, and it's not a way that really undermines the trajectory of where this administration and where the legislature says it wants to go. We can make lots of significant investments, but we shouldn't be making those investments by not paying our current bills. You got to pay your current bills and invest at the same time.
Which of those investments would you cut back by $500,000?
It's not $500,000, so it's
Not $500 million.
they're playing. It's $100 million in each year. So in other words, they're increasing their spending by $1.6 billion, and we're suggesting, well, you can increase your spending by $1.5 billion, and that $100 million that you save by not increasing spending in those areas could actually be in fact used as a way to avoid all of these reductions and increases in taxes. Because those reductions and increases in taxes are going to have to get paid for somewhere.
Which areas do you think they?
Well, I'm not an expert on all of the things that they're looking to invest in and when they're planning to do it. I think there are, obviously the legislature is much more knowledgeable about its timing and when it's planning to make those things. So I think they would be in the best position to decide, could they potentially scale back any of those things, or the timing of those things as a way to avoid some of these changes. So I think there's been reported in various news articles that some of the investments really aren't investments, except maybe after the biennium ends. So
they really don't exist.
What
So
is
they
the
don't
prize?
exist, actually. So when
but I
you
think
talk
you could
about,
all,
yeah.
be better researchers of that.
When you talk about 100 million, so you're talking about basically the increase in.
So I mean, we're looking at the
100
increase of the
each-
taxes,
each
46 million, and the reductions in funding are 58 million.
Each
The
year.
combination, correct, so the
Right.
combination of those two is 105 million per year. So we're saying,
So you're still talking about the hospitals paying taxes, though? I mean, seriously, really? I mean,
well,
this
we
is
would
a
love them
increase.
to
Well, to
undo the
eliminate it.
tax in its entirety, but when we went to the legislature at the beginning of this session, we knew, because we've lived through this before, that that's not gonna happen overnight. And we gave them a thoughtful plan to wind down these taxes over a period of 5 years. So we said, look, if we're net taxpayers of $270 million a year, in this environment, the likelihood of you finding that $270 million someplace else, while we would love that to happen, is fairly remote. But we don't want you to make that obligation bigger, and we want you to start shrinking that obligation and doing it over a period of 5 years.
Right, so you're talking about shrinking what they're increasing, or proposed increasing for the biennium.
Right, if they did what we suggested, which is use 100 million of that extra $1.5 billion in spending, or 2.4 billion in spending, you could actually begin to roll back the impact of the tax by about $100 million a year. Because you would use the funding to match it. And it's a fairly complicated thing, but when you take that money and you make it Medicaid spending, the federal government gives you additional funding. So we can actually begin to roll back the impact of the tax in a fairly significant way. Which it might not take your $1,000 emergency room visit down to something that you thought was
I'm
reasonable.
back to that, don't you?
But it might make it less. And I think Martin can give you kind of a global view, but about 40% of that amount you paid was due to the fact that the state and the federal government underpay for services. And that's a huge portion of what you're paying for in your costs.
It's now out of my pocket.
Yeah.
You said that over the last 3 years you have reduced costs. Who sees the savings? Your patients or the hospital? Because I don't see savings. That's the reason why I'm there. I don't see.
That's my point, is that where the savings are going, they're going to subsidize the state of Connecticut's tax cuts. The plan that we put in place would have allowed us to continue to run a robust organization making investments, and would have allowed us to reduce the rates that we charge. But we can't do that when the state comes in and says, oh, by the way, in 3 weeks, we're going to reduce your payments by $60 million, or tax you and reduce your payments by $60 million. So I'm sharing with you that all of that is going to meet unanticipated further reductions by the state of Connecticut. And the way Steve put it, is absolutely right. Corporations through individuals now, because all of us as individuals are paying a larger and larger portion of our healthcare insurance responsibility. We've got higher co-pays, we've got higher deductibles. They're doing that because the Affordable Care Act put in place a Cadillac tax and said basically you've got to create a way to reduce your spend, or you're going to end up with a tax. And so what happens is you, I are paying part of this tax to the state of Connecticut. They are taxing you.
So when you go up and talk to people, you have to argue for this plan versus the 220 million in taxes that the governor's suggested be cut on businesses. I mean, that's, they're looking for 220 million.
Well, I think
Cuts a year,
I think
I
it's
guess,
100
right?
million per year
100 million
for the
per year.
businesses, right? So it's 220 over the biennium.
Biennium, okay.
Correct.
Sorry, but I mean, that's one thing you have to argue essentially.
And Yale New
against it.
Haven is $60 million roughly of the 100 million. So as
58%.
it
56%, sorry.
and that's because, in effect, the formula that has been created penalizes us for being the largest provider of care to the medically indigent.
The way the formula is structured, it gives credit up to $50 million in Medicaid services we provide. Yale New Haven provides $180 million a year. So any dollar over $50 million we don't get credit for. And as a result, we're penalized by that formula.
Because one of the things the governor's budget did, his proposal that the legislature kept intact throughout the finance process and even into the actual final budget passage was that the governor's office suggested rebasing the tax from 2009 when it was a different situation for
It was
Yale.
pre-St. Raphael
Pre-St.
integration
Rapes.
for us.
So they rebased to 2013, which, and there's a cap on how much you can get back, and that's what has affected.
So it was a double win
Yes,
for
yes.
us, actually.
So there wasn't a cap before? Prior?
No, there was, but they didn't have,
Yeah.
You didn't have-
We didn't, because it was St.
St.
Raphael's and
Raphael's
Yale New Haven were
and Yale New Haven
separately
both had the
reported.
$50 million
So they
cap,
each
and now we just
individually
did
got it, so it was the
59.
equivalent of a $100 million cap, and so when they rebased it, as Kim said, from 2009, 2013, our organizations had come together, so we got one $50 million credit cap, not the two.
But you were
Does that
aware
argue
was
for,
gonna happen,
maybe
right?
you should
I'm
combine
saying.
them? I'm sorry, does that argue for that perhaps you shouldn't have combined risks?
No, so let me tell you. So the tax issue is one issue, and that's gotten, obviously, it was compounded when you increase the rates, et cetera. But the bottom line is the St. Raphael integration, our goal was to save $300 million over 5 years, and we're well on our way to doing that. Absent that integration, there was, it would have been extraordinarily difficult. I won't say there was no way, but it would have been extraordinarily difficult for us to even meet the needs from the last round of cuts. Remember, the last cycle was in 2011. There was over $500 million in that biennial budget for cuts to Medicaid cuts to hospitals. Had we not done that integration at this point, we would have been in a much different place because the efficiencies were able to drive. That's why those types of partnerships and those affiliations, those types of integrations are critical to hospitals moving forward.
I got one final question. Seems that hospitals in Europe and other countries are able to provide services to people, and everything is fine. It's only here in America that it seems that healthcare is such a major problem. Other places, people get care, and hospitals are making money, and everybody's happy.
You and I probably should go out to lunch and talk, because you're interested.
You'll have the treat.
Yeah, well, I know, but you're interested, I love the fact that you're interested in this, and there's actually a woman at Yale named Betsy Bradley who has written some of the Sentinel work on this, and she wrote a book called, I think, The American Healthcare Paradox, or The Paradox of American Healthcare. But basically, she and other people who have written about this say that, we can sort of convince ourselves into believing that we're too expensive and we're not producing good outcomes for the money that we're spending. That's basically the premise, that we see all the time. But when we make the comparisons, we're not looking at all of the variables that are important. So as an example, in most of the developed Western European countries that we're compared with, if you also looked at the governmental spending on social infrastructure, on education, on housing, on other services, plus healthcare, you would actually see, and then looked at what we spend as a government, on education, on housing, on social services and healthcare, on a per capita basis, there isn't a huge difference. The difference is where we spend it. We don't spend it at the same levels on education, housing, and other infrastructure. We spend it all on healthcare, and we have effectively created systems that incent the providers to do stuff when sick people come in, to take care of them. These other countries have made investments. I mean, you know, there are a lot of data that say that when people are better educated, when they live in safe housing, when they have access to good food, they do not have the same level of chronic condition and illness that we have in this country. So we're kind of paying for, you know, what we didn't invest in up front. And, you know, one of the hypotheses is that if we could develop, you know, working capital to make more thoughtful investments in other parts of our social infrastructure, it'll take a while because we got a lot of Medicare people who are coming out with chronic heart disease and diabetes and all kinds of things, but you can change that demand. So that's one big factor that they talk about. It's a really great book, and she lives just in New Haven. Second thing that they talk about is that Western European countries spend far less on end-of-life care than we do. If you look at, I mean, you know, we could probably, you know, and I'm not an economist, but we could fund a lot of what we think are underinvestments in education and housing and other social infrastructure if we had some policy about end-of-life care, because we spend a huge amount of money in the last months of people's lives without any clear outcome. But, you know, whenever that's raised in political discussions, people go, oh my gosh, it's death panels, you know, and you get into this very negative conversation. And I think that that's a conversation that we're gonna have because any way you look at the Affordable Care Act and when the Medicare Trust Fund is supposed to go bankrupt, you know, they keep kicking that can down the road, which is a good thing, but it isn't gonna be sustainable. And you know, I think we ought to be putting it into education, into immunization, and not so much of it into, you know, intensive care for people who are, you know, elderly, who do not have the potential to come out with the same quality of life. But, you know, those are very, very difficult conversations. So I think, you know, you're raising a really important point. And the answers are very complicated, but we got to look at it more holistically than just healthcare and healthcare spending, I think. And I will pay for lunch.
They're also taxed more in some of those
Yes.
states.
Yes.
Yes, that's true. Individuals are taxed much more heavily than they are here to pay for that
We also have
infrastructure.
single payer systems, which should have, I think.
Any upset?
Yeah,
Thank you very much.
Thank you.
Thank you.
Thank you.
thank you, guys.